Oncology TV at ASCO 2015. Thomas Baldrick with Elizabeth Buchbinder from the Dana-Farber Cancer Center Institute in Boston, Massachusetts. Thank you for stopping by. So you're here to share your retrospective analysis in metastatic melanoma and metastatic renal cell carcinoma. Let's begin with the PROCLAIM patient registry. What is an explanation of it?
So the PROCLAIM registry, what it is it's basically a database of patients that have gotten IL-2 from over 40 centers across the country. There's two parts to it. So there's one that's retrospective, because when it started, they wanted to pull cases from patients that had already gotten IL-2. So there's that part, and then there's a prospective part where they're basically anyone new who gets IL-2 gets put into the database, and then they follow how they do, what other treatments they get, and kind of what toxicities and other problems they get going forward. So it's a chance to really look at how patients are getting IL-2, how they're doing on it, and also how it's interacting with other therapies.
One of the ways where technology has changed cancer research. Imagine doing this without modern technology.
You couldn't do it, and from so many centers across the country, to be able to get that kind of information is invaluable.
So what were you looking to achieve?
So what's happening in melanoma, as everybody at this conference knows, is the immune checkpoint inhibitors are doing amazingly well. We're going to hear about it more in the plenary. We've heard about it yesterday from Dr. Hody, and they're really moving into the front line in terms of therapy for melanoma and therapy for renal cell cancer. And so as a result, some of the older therapies we used are kind of moving back. And the question is, are they still safe to give second line? So after immune checkpoint blockade, is it still safe to give IL-2? Is there more toxicity because of how you've changed the immune system? And then also, is there any benefit? So if they don't respond to immune checkpoint blockade, are they then going to not respond to another immune therapy, which is IL-2? And we wanted to answer those questions. Unfortunately, at this point, the only way to really look at that is to kind of pull what's happening around the country and see what people are doing, pull the cases that are happening and take a look at those numbers. Until we know whether it's safe, it's going to be hard to do a big trial. And so that's exactly what we wanted to do. And so we looked at all the patients who had gotten prior immune checkpoint blockade and then went on to get IL-2 so that we could see, is it safe, is it effective, and kind of what can people do this in patients that progress.
So what have you gotten for key findings?
So the biggest thing that we saw is that post-ipilimumab, there was no change in terms of efficacy, and we didn't see a huge spike in immune-related events. So there was a lot of worry that because of, especially the colitis you see with ipilimumab, that you may have a flare as soon as you start the IL-2. There's case reports here and there, but all in all, the immune toxicity was manageable, and most of the toxicity was manageable. The next thing we looked at is post-PD-1 patients, so patients who'd gotten any of the anti-PD-1 or anti-PD-L1 therapies. So far, we've been able to find 11 cases, and as we've been presenting our poster, more and more have been coming up, so we're going to add more of the analysis. And the exciting thing about that is that there's quite a few durable responses, people with stable disease, people with some sort of response that is ongoing at this point in the analysis. And so it does appear that there's some activity in IL-2 after PD-1, and so far the toxicity has been relatively manageable as well, very similar to giving IL-2 frontline. And so as a result, it means that from what we can see so far, and we're hoping to kind of keep building on these numbers and keep reporting as time goes on, IL-2 is a reasonable option after immune checkpoint blockade in patients that fail that therapy.
So how does this study fit in with the conversation on immunotherapy here at the
I think there's
conference?
A bunch of ways it fits in. So I think it fits in, one, in terms of what are we going to do? There are some people not responding to these therapies. What do we do for them? Two, I think it fits in terms of future combinations, future sequencing. You know, what agent should we be doing first, second? Should we be combining them all together? Should we be putting IL-2 with some of these other immune checkpoint blockade therapies or other immune therapies that are in the pipeline? And kind of how are we going to work it all to optimize the response in terms of really getting the most patients to have that wonderful, durable response, and that what we refer to as treatment-free survival, where they don't need any more treatment because their disease is under control.
So you have lots of opportunities. What do you do next with this?
Yeah, so we're going to keep growing this. We work with a bunch of people who give IL-2, so we're pulling in as many cases as we can. Since the database is prospective, we're going to keep following how people do going forward. And we're going to try and see first off, just to pull as much as we can right now so that we can get it out there, but then also continuing to follow these people in terms of this data. And then also I think we are looking at new combinations, trying to see if there's a role for IL-2 in combination with some of these other therapies.
Excellent. Thank you. Come back and keep us posted, would you?
Absolutely. Thanks.
Yes, sir.